You all ready to get started?
Let's
All right, let's go ahead and do it. We'll let people trickle in here in a moment. Good morning, everybody. Welcome back to Grand Rounds here at the Department of Medicine at Washington University School of Medicine. I'm John Hickman, one of the chief residents. It's my pleasure, as always, to welcome you here on behalf of our chair, Dr. Frazier, Drs. Costco, Spencer, and myself. Thank you for joining us. I am very excited for today's talk with a very special speaker. As always, we should have time for some questions, so please send them along through the chat and the Q&A function. If you missed any past talks, head over to the Department of Medicine website, check out our YouTube channel. We should have most of the talks we've had there uploaded, so please just take a look and see if there's anything that piques your interest. Leave us some feedback if you have any speakers that you'd like to see in the future or any comments on any past talks. Today, we have a fantastic one, and we are joined by Dr. Tony Dow. He is an instructor in medicine and one of our associate program directors, one of my favorite residents and now attendings, and is also serving as the director of the OutMed program, and here to introduce our speaker. Welcome, Tony.
Thank you, Dr. Hickman. As he said, my name is Tony Dow. I'm the director of OutMed. I'm pleased to introduce Dr. Joseph Cherabie for our third OutMed lecture. The OutMed lecture was created several years ago by Dr. Kara Sternal-Blackwell to promote LGBTQI+ visibility and topics into the Department of Medicine Grand Rounds. Dr. Cherabie recently completed his infectious diseases fellowship here with us just last year. His passions in sexual health and STI and HIV prevention lend him well to his multiple leadership positions. First, as the director of the Capacity Building Assistance Program, or our PrEP program. Second, as the associate medical director of the St. Louis County Sexual Health Clinic. And lastly, as the associate medical director of the St. Louis STI and HIV Prevention Training Center. Dr. Cherabie is an astute clinician, a budding investigator, and a great teacher. He is also a fierce advocate for the St. Louis and Washington University communities by increasing access to marginalized patients through his advocacy work and sexual health education to state and local health departments. He augments medical student, resident, and fellow medical education by applying an LGBTQI+ lens in his teaching when needed. We're proud to have Dr. Cherabie represent OutMed this year in our OutMed lecture. So I'd like to welcome Dr. Joseph Cherabie to discuss the new PrEP guidelines.
Thank you so much, Tony. That was a wonderful introduction. I will be sharing my slides. One second. All right, can everyone see my slides?
Looks great.
Wonderful. Well, first off, thank you for that wonderful introduction. And I'm really excited to be able to give the OutMed lecture this year. So today I will be talking about applying a trauma-informed care lens to the 2021 CDC PrEP treatment guidelines. And the objectives of this talk are to go over the basics of HIV pre-exposure prophylaxis care, an introduction to trauma-informed care, an overview of the major changes of the 2021 CDC PrEP treatment guidelines, and a little bit of a discussion on implementation of PrEP care. So first and foremost, what do we mean when we say HIV prevention? What's the first thing that pops into our head? And oftentimes the first thing that, you know, in any of the talks we give, people say, well, condoms or any kind of barriers in sexual health. So I think that's a great first thought. It means that the messaging has worked up until now, but I like to think of HIV prevention as being more nuanced than that, where barriers and contraception play a role in what I call the HIV Prevention Pentad, and you could see it on the left, but it also needs to be coupled with adequate screening and treatment of our patients, not only for HIV, but also for sexually transmitted infections. We know that having a sexually transmitted infection increases the likelihood of acquisition of HIV. And so we need to adequately screen and treat our patient population for these diseases. But let's not just stop there. We also need to speak about our patients' sexual partners and making sure that their partners, if our patients have an STI or HIV, are also notified and treated adequately. And then comes in the aspect of medical therapy, which we'll be delving deep into today, in that we will be discussing pre and post-exposure prophylaxis for HIV. But all of this intersects into what should be individualized patient care. We really need to speak to our patients and talk to them about their sexual health and discuss with them if they're having the type of sex they want to have, what their sexual health goals are, and how we can have those discussions with our patients openly and honestly. Because, while barriers might not work for some people, then we need to start talking to them about adequate screening, regular screening. We could talk to them about pre and post-exposure prophylaxis if necessary. But it all goes back into providing the healthcare that our patients need and meeting them where they are at to make sure that they are meeting their sexual health goals. And we'll delve deeper into that later on in the talk. So let's go over some PrEP basics. And first and foremost, we'll be talking about HIV epidemiology. So as of 2019, there are 1.19 million people in the US living with HIV. There were around 36,800 new HIV diagnoses in 2019, and that represented a decrease of 9% from 2015. You can see the breakdown of the new HIV diagnosis or the incident HIV diagnosis based off of sexual interactions or modes of acquisition and based off of race and ethnicity. So the highest rates were from male to male sexual contact, followed by heterosexual contact, then injection drug use, and then they have an added category of combined male-to-male sexual contact and injection drug use. To the right, you see the breakdown based off of race and ethnicity. So the highest rates of acquisition were amongst Black and African American individuals, followed by the Hispanic and Latinx community and white individuals. When broken down based off of not only race and ethnicity, but also sexual contact, you see that the highest rates are amongst Black and African American male-to-male sexual contact, or men who have sex with men, followed by Hispanic and Latinx MSM, and then white MSM. And then you have the breakdown based off of, then you see the category of Black and African American women through heterosexual contact. And so these are taken straight from the CDC website. And you can see here that they say that Black and African American, as well as Hispanic and Latinx people, are disproportionately affected by HIV, with gay and bisexual men being the population most affected by HIV. And there's further breakdown based off of transgender individuals. To the left, you see the breakdown in transgender women versus the right in transgender men. Automatically, you see that there are higher rates amongst transgender women, with the highest rates being amongst Black and African American transgender individuals, followed by Hispanic and Latinx, and then white, especially in transgender women. So you can see that there are race and ethnic disparities across the board, especially in sexual health. And we know this, that race and ethnic disparities occur throughout healthcare, but they are further exacerbated, especially in the sexual healthcare field. So just briefly, what are the HIV testing recommendations? So the CDC recommends that everyone between the ages of 13 to 64 be tested at least once for HIV, with more frequent testing for individuals who are at increased risk for HIV to at least annual screening. Then you can see here the USPSTF recommendations for pregnant individuals to be screened at every pregnancy, as well as for adolescents and adults aged 15 to 65 recommends at least one-time screening, and for those of increased risk should also be screened. So let's talk about PrEP a little bit. So there are two things, PrEP and PEP. PrEP is pre-exposure prophylaxis. In other words, taking antiretroviral therapy medications before you are exposed to HIV in order to prevent acquisition of HIV. Whereas post-exposure prophylaxis, or PEP, is antiretroviral therapy that is given after a person might be exposed to HIV, and therefore given for a 4-week-long course. And oftentimes giving post-exposure prophylaxis is a means of transitioning someone from PEP to PrEP afterwards as well. So they sound similar, they are slightly different. And this is just the PrEP guidelines timeline. And so I would have loved to have gone over every single study that went into approval of PrEP, but I only have an hour today. So we will be talking, this is just the major updates and the major timeline points along the PrEP approval timeline. So in 2012, Truvada, otherwise known as tenofovir disoproxil fumarate with emtricitabine TDF-FTC, was approved by the FDA for HIV pre-exposure prophylaxis. The first guidelines came out in 2014 by the CDC, which recommended a daily HIV prevention pill for those at substantial risk. In 2017, there were updated CDC PrEP guidelines, and this was the iteration that was used up until last year. And so this was our most recent iteration, which we'll go over shortly. And then in 2019, Descovy, otherwise known as tenofovir alafenamide with emtricitabine TAF-FTC, was approved by the FDA for pre-exposure prophylaxis, specifically among cisgender men who have sex with cisgender men and transgender women. The reason being, those were the populations in which that medication was studied in. Then in 2021 was a big year for PrEP. Injectable cavitegravir was approved for pre-exposure prophylaxis, and we had an update in the guidelines. And so very exciting time, and hence why I'm speaking here today. So let's go over the previous iteration of the guidelines just to go over, what things were like in 2017, and so we can highlight some of the major changes that occurred in 2021. So you see the breakdown here based off of risk group. Men who have sex with men being in one category, self-identified heterosexual women and men being in another, and persons who inject drugs. For men who have sex with men as well as heterosexual women and men, the breakdown of the indications for HIV pre-exposure prophylaxis were if an individual had an HIV positive sexual partner, a recent bacterial STI, a high number of sex partners, history of inconsistent or no condom use in commercial sex work. And you can see it's similar between men who have sex with men and heterosexual women and men. As for persons who inject drugs, the indications were if they had an HIV positive injecting partner, as well as if they had sharing of injection equipment. You needed a documented negative HIV test prior to prescribing PrEP and no signs or symptoms of acute HIV infection with a normal renal function and a documented hepatitis B virus infection or vaccination status. Afterwards, you could provide less than or equal to a 90-day supply of Truvada. Mind you, this iteration of the guidelines came out before Descovy or TAF-FTC was approved. And then you would want to follow up every 3 months. At least every 3 months. Some people would do a follow-up at 1 month just to make sure people are doing okay and to rule out an acute HIV infection. But amongst men who have sex with men, the recommendation was to do oral and rectal STI testing, specifically for gonorrhea and chlamydia, and you would want to screen through a blood sample for syphilis. And then for self-identified heterosexual individuals, you would want to assess for pregnancy intent in those individuals who could be pregnant, as well as a pregnancy test every 3 months. And for persons who inject drugs, you want to make sure that they have access to clean needles and syringes and drug treatment services. So you may be asking, how effective is HIV pre-exposure prophylaxis? For sexual transmission or acquisition, it actually can be up to 99% effective with daily medication use. So the more frequent and the more regularly our patients take HIV pre-exposure prophylaxis, that effectiveness can go up to 99%. I do want to highlight, though, that the effectiveness that is measured for injection drug use, while it may seem lower, there are not many studies that were performed within this population, and most of those studies that were performed were using tenofovir alone. And so there are studies coming down the line, fingers crossed, and hopefully, but that's why that effectiveness rate looks a little bit lower in that population. But overall, HIV pre-exposure prophylaxis is part of the federal plan of the Ending the HIV Epidemic, which has 4 pillars. Number 1 being diagnosing all individuals with HIV as early as possible after infection. Number 2, treating HIV infection rapidly and effectively to achieve sustained viral load suppression. Number 3, preventing at-risk individuals from acquiring HIV infection, including the use of pre-exposure prophylaxis, which we'll be talking about today. And number 4, rapidly detecting and responding to emerging clusters of HIV infection to further reduce new transmissions. So how are we doing with respect to PrEP uptake in the United States? So this was an MMWR report that was released in 2018 that shows uptake based off of sex and breakdown by race and ethnicity. automatically you could see that there's a huge disparity with uptake amongst white individuals being much higher than those amongst Black and our Hispanic and Latinx community, as well as our Asian communities. And then you see that there's a disparity based off of sex, with cisgender men or males being having a way higher uptake than female PrEP users, which you see on the right as those little tiny blips on that bar graph. Another MMWR report was released in 2019 that looked at the uptake of HIV pre-exposure prophylaxis, basically trying to see how many of the individuals who actually met indications for pre-exposure prophylaxis were actually on pre-exposure prophylaxis. So overall, 18.1% of individuals who met indications were actually on PrEP. And then we have, again, a disparity based off of race and ethnicity, in which 5.9% of Black individuals who met indications actually being on PrEP, 10.9% of Hispanic and Latinx individuals who met indications being on PrEP, compared to 42.1% of white individuals who met indications actually being on PrEP. So there's a high uptake amongst white individuals, but we're not seeing that same uptake amongst Black and our Hispanic and Latinx population. There's also an age disparity, with the highest uptake being amongst the age range of 25 to 44 years of age. And that tapers out when you go into a younger age group as well as the older age group. So without further ado, let's talk a little bit about trauma-informed care. And I want you to pay attention to some of the words that I just said throughout the first part of my presentation. A lot of those words I don't normally use in my presentation, but I'm trying to prove a point here, which is that some of those words are taken directly from the guidelines. Things like at-risk individuals, high-risk sexual behavior, clean needles, dirty needles, safe sexual practices, unsafe sexual practices. While these terms in and of themselves have been used for years, especially with respect to public health messaging, and you can see examples of public health messaging in the posters on the top of the slide, while these have been tried to indicate and try to improve people's health, oftentimes the language that we use could end up stigmatizing those individuals that we are actually trying to help at the end of the day. Because in saying that, for example, in saying that an individual is practicing unsafe sex or is having high-risk sexual behavior, it might cause them to disengage from the healthcare system that we actually want to engage people into, right? I can tell you that I myself have sought healthcare for getting STI screening or trying to be on PrEP, and have been told that my sexual behavior has been deemed risky or too high risk. And I can tell you that automatically I wanted to disengage from the healthcare system. I didn't want to go back to that place where I felt judged, where I felt like I was already doing a good job judging myself in that situation, because when people go to a sexual health clinic or a PrEP care clinic, they're all automatically worried about what they might find on these screenings. So let's talk a little bit more about that, and let's delve a little bit more into trauma-informed care and the language that we use and its effect on how we interact with our patients. So I always like to start my talks on trauma-informed care and most of my talks with this definition by the WHO on what sexual health is. Sexual health is a state of physical, emotional, mental, and social well-being in relation to sexuality. It is not merely the absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. For sexual health to be attained and maintained, the sexual rights of all persons must be respected, protected, and fulfilled. I read that whole definition every single time I present this slide, because when we talk about sexual health, oftentimes what we're talking about is preventing disease or making sure that there is the absence of disease. But in doing so, we oftentimes forget the rest of what sexual health should be, focusing on the physical, emotional, mental, social well-being in relation to sexuality. It's not merely the absence of disease. It is really, we need to focus more on the whole picture of what sexual health is in order to make sure that our patients are having the type of sexual life that they want to have, the type of sex they want to have in a healthy manner. So I bring back up the slides that I presented at the beginning of this talk. And so the reason I do this is because, again, these are from the CDC website. And automatically, when you look at information like this, you are making indirect connections between population rates in a population and the individuals right in front of you. So if, for example, I had a Black MSM patient in front of me, in medicine, we are trained to think, okay, well, the highest rates of HIV are amongst this population, but that might not apply to the individual seated right in front of us. That individual might have a sex life in which they have one sexual partner, they don't have any other sexual partners, and that doesn't necessarily mean that I have to apply that population risk into that individual right in front of me. Also, we need to remember that when we are speaking to our patients, we need to not use certain terms like you are a high-risk population. It is not the fact that this person is a member of a particular population that means that they have higher rates of these diseases. We need to ask why there are high rates of diseases amongst these particular populations. Could it be that we have yet to reach out to these populations? They don't have adequate access to the healthcare that they need, like sexual health screening, like STI screening, HIV care. Could there be a lot of stigma and discrimination amongst this population with respect to STIs, HIV, and sexual health care? Yes, so it's multifaceted. It's not enough to say that there are high rates amongst these particular populations. We need to ask why. Also, within the 2017 guidelines, I just want to highlight certain things that, in my opinion, might isolate and stigmatize a certain set of populations. You notice that the indications for cisgender men who have sex with cisgender men and heterosexual men and women are the same. So why are we separating the two categories? Why are we othering them? Also, what is a high number of sexual partners? I have yet to find out what that means and how anyone can define it. The best definition I've ever seen is by my former mentor, Dr. Donna Sweet, who said that a high number of sex partners is a person who's had one more sexual partner than you. And so each of us might define a high number of sex partners differently, and it's not clear what exactly that means. And then if you look under the category of persons who inject drugs, access to clean needles, in and of itself, saying something is clean as opposed to being dirty, and it adds a certain value judgment that might not be, it might not be directly trying to harm people, but it might inadvertently stigmatize individuals. So why not say things like sterile needles, for example? So here comes trauma-informed care and how we define it. So a trauma-informed approach is the human service field that assumes that an individual is more likely than not to have a history of trauma. Trauma-informed principles recognize the presence of trauma symptoms and acknowledge the role trauma may play in an individual's life. So what is trauma? And I've taken the slide courtesy of my colleague, Jeremy Bashir's, but we like to separate trauma into two categories, big T's and little t's. Big T's in and of themselves are more socially validated. They're what we consider to be more extreme, things like shock trauma. So things that if this occurs to you, most of society would assume, oh yeah, I can understand how this could have had a traumatic effect on an individual. Things like natural disasters, mass shootings, sexual violence, war, terrorism, torture, burglary, car accidents, kidnapping, physical abuse, and hate crimes. Whereas little t's are less validated socially. They are daily, subtle, and often involve a persistent lack of control and/or power. So things like weight stigma, body shaming, poverty, discrimination, transphobia, harassment, bullying, neglect, heterosexism, racism, slut shaming, homophobia, all of these might occur subtly on a daily basis and might slowly chip away at an individual and cause a trauma that might not be evident all at once, but once it can have a very subtle and with time, a long-lasting traumatic effect on an individual. But because it's more subtle, it's not as visible and it's not as clearly delineated as, for example, having a big trauma. All of these are equally valid though, and we need to remember that when we're talking to people and our patients. And so let's talk about the LGBT community a little bit. This is the reason why I want to bring this up is because the LGBT community is oftentimes experience these little t's and sometimes some of the big t's as well. But This is a population that has been discriminated against and oftentimes left out of the healthcare community. And we have to ask ourselves once again why that is. Because while they have been left out of the healthcare systems for quite some time, we also notice that they are being highlighted as one of these priority populations for HIV prevention mechanisms, right? And so this survey, which is the Center for American Progress survey from 2017, highlights a lot of these points that amongst lesbian, gay, and bisexual and queer respondents, 8% of people said their doctor or other healthcare provider refused to see them because of their actual or perceived sexual orientation. And 7% said they experienced unwanted physical contact from a doctor or other healthcare provider, such as fondling, sexual assault, or rape. These statistics become even more stark when we start talking about the transgender population, in which 29% said that a doctor or other healthcare provider refused to see them because of their actual or perceived gender identity. And 29% also said that they experienced unwanted physical contact from a doctor or other healthcare provider, such as fondling, sexual assault, or rape. That's around 1 in 3. It's a startling statistic to read, but when we ask, why these individuals might not want to engage in the healthcare system, we have to remember that oftentimes some of the trauma that these individuals have experienced were because of the healthcare system. We ourselves may have inflicted trauma on this population, and we ourselves have to undo that trauma. And so how can we do so? Oftentimes it starts with simple language shifts. And so I want to highlight some of these words that we oftentimes use that will be found in guidelines, that will be found anywhere. But I want to highlight the effect that, and when you hear some of these words, I want you to think about being a patient in a room, hearing your doctor say these words at you and what that might feel like. And so first, let's talk about prevention. Prevention in and of itself is the act or practice of stopping something bad from happening. So when you are saying HIV prevention, STI prevention, it automatically means that it might make the connection that someone who acquires HIV, something bad has happened to them. And so and it might create some sort of fear. There's some kind of danger that you are trying to prevent, especially in sexual health. And let me tell you, if you're having sex, the last thing you want to be is afraid of something, right? And so instead, let's talk about sexual health goal setting. And that's a more all-encompassing view of sexual health. That fits in with the definition of sexual health that I shared earlier. That when we talk about sexual health, it shouldn't just be the absence of disease that we are focusing on. We need to talk about pleasure. We need to talk about if people are enjoying themselves, if they are having the type of sex they want to have with the people they want to be having sex with. Next, let's talk about safety. Safety is a big one. And safety is the condition of being protected from or unlikely to cause danger, risk, or injury. So we talk about safe sex all of the time, but when people talk about safe sex, oftentimes they're talking about condoms or barriers. But instead, let's talk about sexual health and well-being, empowerment, pleasure, and consent. Because in my opinion, once all of these categories are met, then that, in my opinion, is safer sex than any condom or barrier can provide. And so we need to talk about people if they are having the type of sex that that they want to have in a consensual manner that empowers them and allows them to take control of their sexual health and well-being. Risk is a big one. We use risk all of the time in terms of research, but we have to remember that risk is a situation involving exposure to danger. So when we talk about risk ratios, hazard ratios, high risk populations, it can be quite stigmatizing. It can cause people to just disengage and say, well, I'm having risky sex. For PrEP care, for the longest time, we were actually using ICD-10 codes that said high risk sexual behaviors. And I have actually had patients come up to me and say, why are you calling me high risk? I'm actually putting myself on PrEP. Like, that's a good thing. And they're right. Why were we using that term? And so instead of risk, I highly recommend when you're talking to your patients to talk about susceptibility, sensitivity, vulnerability, likelihood of acquisition. This decreases the stigma and kind of allows you to empower your patients more in terms of taking control of their sexual health. What about non-compliance? We say non-compliance or non-adherence. That's failure or refusal to comply with something such as a rule or regulation. So instead, I like to ask, are you able to take medication every day? If not, then how can we help you to take medications every day and as they are prescribed? And just trying to ask, how can I help? what are the things that we can do to empower you? And then transmission is to pass or spread a disease or infection to another. And you'll notice that I say acquisition quite a lot when we're talking about HIV. But all of this goes back to taking a good sexual history. And this was a guide released last year by the CDC, who the primary author was our own Dr. Hillary Reno, and they updated the 5 Ps. And so the 5 Ps are partners, practices, protection from STIs, past history of STIs, and pregnancy intention. So for partners, asking what are the genders of your sexual partners? How many sexual partners have you had in the last 6 months, 12 months? And, when I say, I always ask, what are the genders of your sexual partners, leaving it open-ended in order to allow for gender diverse individuals to be able to share their partners. What are the sexual practices you are having? Are you having oral, vaginal, anal sex? And understanding that people define sex differently. There's a study that showed that 60% of individuals do not think that oral sex is sex. So let's talk about all different types of sexual practices. Protection from STIs, again, not just barriers, not just condoms. Let's talk about access to vaccines for HPV, hepatitis A, hepatitis B. Let's talk about if you are using HIV pre-exposure prophylaxis. Past history of STIs is very important to know, as well as pregnancy intention. It used to be pregnancy prevention, but some people want to be pregnant. So we are allowing people to have the intent to be pregnant. But some people have said, I want 3 more Ps. And so number 1 of the additional 3 Ps is preferences, talking about what your preferences are, what your sexual preferences are, and having an open discussion about how you can have that discussion with your partners as well. Pleasure, believe it or not, sex is pleasurable, and we don't talk to our patients about how pleasurable their sex is, and we should be talking to them, because if they are not having pleasure with sex, then we need to have an open discussion as to why they are not. And then last is partner violence. A lot of our patients are survivors of sexual assault, and we need to be able to have open and honest discussions about that with our patients in order to provide them the care that they need. So without further ado, as I take a sip of my coffee, with that lens, I want you to look at the update from the 2021 CDC PrEP guidelines. And there's some major changes that we're going to go over. So number 1 is there's increased and simplified indications. There's the whole goal of these guidelines was also to increase access to PrEP. And there are more options for PrEP, being TAF FTC as well as injectable cavitegravir. And in these guidelines are information on how to give out injectable cavitegravir. And then laboratory changes, some simpler and some more complex. So let's go over the first thing, which is more indications. So automatically there is an added recommendation to inform all sexually active adults and adolescents about HIV pre-exposure prophylaxis, which is amazing and huge, because gone are the days of us trying to assess individuals based off of if they are high risk, if they are low risk. We are done doing that. Instead, the recommendation is to talk to all sexually active adolescents and adults about HIV pre-exposure prophylaxis. There's also simplified indications for PrEP for all sexually active adults and persons who inject drugs. So we're no longer separating cisgender men who have sex with cisgender men and self-identified heterosexual individuals. We're just saying sexually active adults and adolescents who, and the indications are if they've had anal or vaginal sex in the last 6 months in any of the following: an HIV positive sexual partner, bacterial STI in the last 6 months, or a history of inconsistent or no condom use. As for persons who inject drugs, the indications are HIV positive injecting partners or sharing injection equipment. You need a documented negative HIV antigen antibody test within 1 week before initially prescribing PrEP, and no signs or symptoms of acute HIV infection, with an estimated creatinine clearance of greater than 30. And then you can see there's options for TDF FTC as well as TAF FTC. Once again, TAF FTC is only for cisgender men and transgender women. So in the guidelines is this language that says routinely taking a sexual history is a necessary first step to identify what specific sexual behaviors may place an individual at an increased likelihood or a decreased likelihood of HIV acquisition. Notice I changed that language myself. We're trying to remove risk from how we talk about HIV prevention, but it should not be limited to selected patients. It should be applicable to all patients. And so you'll see this up here in this algorithm that is also included in the guidelines of assessing indications for HIV pre-exposure prophylaxis in sexually active individuals. It looks like a complicated algorithm. I promise you, it is a lot easier than it looks. And when we get to the bottom, I'll explain why. But you want to ask if they've had anal or vaginal sex in the last 6 months. And then instead of asking if they've had sex with men, women, or both, which again, you'll see this quite frequently, I've made my changes in the red boxes. It's better to ask open-endedly, what are the genders of your sexual partners? It just allows, it is more inclusive. And so then you want to see if they've had an HIV positive infection partner, have had sex with one or more sex partners of unknown HIV status, or had a bacterial STI in the past 6 months. And then instead of asking, do you always use condoms? As if, you know, some people just condoms does not work for them. And you just want to ask them, how often do you use condoms? I congratulate any of my patients that use condoms at all. But, you know, you just want to meet them where they are at in a non-judgmental manner. If I said that, are you always using condoms? That means you should always be using condoms. And if you're not, you're doing something bad. And that might make them feel a little bit judged or stigmatized. But then you go down to the bottom of the algorithm. And yes, if they meet those indications, you prescribe PrEP. But this is a major change. If they don't meet those algorithms, it says discuss PrEP and prescribe if requested. While that may sound commonsensical, this is actually a big change in which we are prescribing PrEP based off of people requesting it. So I can tell you, I took an ID board practice question that actually I screamed at that said that this patient who was coming to my clinic asking for PrEP did not meet, you know, the indications for PrEP because they were too low risk. If a patient is coming to me asking for pre-exposure prophylaxis and took time out of their day to do so, then likelihood is I would give them that. And so this fits in line with how we are actually practicing medicine. And so this is a big change and is a wonderful welcome change in terms of the guidelines. This is the algorithm for persons who inject drugs. And I just want to highlight, again, it says prescribe if requested, which is wonderful, but also to assess the sexual health of all persons who inject drugs, because we have to remember persons who inject drugs also are sexually active. They do have increased rates of STIs, as we are finding through the work of some of my colleagues, such as Dr. Laura Marks. And so it is really important for us to take a good sexual history in persons who inject drugs as well. So prescribe if requested. Big, wonderful, happy to see it. And I think this is a much more inclusive and a much less it's a much more trauma-informed way of actually looking at the patients in front of us and meeting them at their sexual health goals of what they would like and focusing less on quote unquote risk. We also have increased access to PrEP. So again, there are more options now. You have TDF-FTC, which is approved for all sexually active individuals. That was trade name Truvada. And now it's generic, which is wonderful, which means that we have even more access to individuals who couldn't previously afford it. And then TAF-FTC, trade name Descovy, was FDA approved as of 2019 through the Discover trial, which we'll speak about in a little bit. But it is approved for cisgender men, specifically MSM, and transgender women. Cavitegravir is the injectable form, which is FDA approved as of 2021 based off of HPTN 083, which it showed superiority, and it is for sexually active adults. Now, we oftentimes get the question of what is, you know, the difference between Truvada versus Descovy, TDF versus TAF. So I do want to highlight some of the differences between the two. So first and foremost, TAF was approved after the Discover trial. The 96-week data showed that TAF-FTC was equally effective compared to TDF-FTC. So I say this because oftentimes when someone rotates with me in the clinic, they say, oh, Descovy's newer, it's better. No, that's not necessarily the case. It is equally effective. And we have to remember why TAF and TDF exist, right? So TDF-FTC is a huge backbone in HIV treatment. And when used in combination with other HIV antiretroviral therapy drugs, it had been shown with long-term use to have an increased rate of kidney disease, specifically Fanconi syndrome, and a decrease in bone mineral density. So a different formulation was made of that tenofovir into tenofovir alafenamide, which interacted less with the kidney, was more rapidly absorbed into the adipose tissue, and had less likely the side effects of affecting the kidneys as well as decreased bone mineral density. But When we have been studying TAF FTC in combination with other antiretroviral therapy drugs, especially integrase inhibitors, we have noticed that there has been an increase in metabolic changes and weight gain as well. And so again, oftentimes these side effects and these adverse effects are in combination with other antiretroviral therapy pills, but we're learning more as people are taking this individually as PrEP, whether these side effects persist. And we're noticing that they're not occurring as much. But still, it's a discussion I have with my patients because, of course, there's lawsuits on the TV that say if your loved one has ever taken Truvada, then you might be entitled to a cash settlement. And so when our patients see that, they might freak out because we are recommending these drugs to them and they want to know. So I go over this shared decision-making model with my patients. I go over the pros and the cons of both. So pro TDF, there's a generic available, there are more indications, there's less metabolic changes and weight gain, and you have the option for on-demand dosing, which we'll speak to on the next slide. The cons, though, is that you have to have a creatinine clearance of greater than 60, and you can have bone density issues. And it's a larger pill, lest we not forget. You know, sometimes swallowing a larger pill is hard. For TAF, on the other hand, the pros are there's less in renal bone complications, can be used for a creatinine clearance of greater than or equal to 30, and it's a smaller pill. But the cons, it can cause possible metabolic changes in weight gain, and there are fewer indications in these scenarios. Again, MSM and transgender women. But at the end of the day, I leave it up to my patients. I allow them to make this decision, and we do share decision making. And I can't, there's no rhyme or reason. It's 50-50 split for my patients. Half of them take Truvada, half of them take Descovy. And so I just want to say this is how we model it in our clinics, and this is how we have that discussion. Now, as for on-demand PrEP or event-based PrEP, this is not FDA approved. I have to highlight that, but it has been studied and it has been looked at in both the iPrEP trial as well as the Prevenir open label real world study. And what that is it's a 2+1+1 regimen. So before you have sex, 2 to 24 hours before you have sex, you take 2 pills, and this is specifically of TDF FTC. And then 24 hours after having sex, you take another pill, and then 48 hours after having sex, you take another pill. And then if you continue to have sex, you continue to take a daily pill as long as you continue to have sexual intercourse. When is this useful? We have a lot of patients that basically say, hey, you know, doc, I'm not having a lot of sex these days. I'm taking this medication. I'm worried about the side effects. So this might be a useful regimen for individuals who are having infrequent sex and are worried about the side effects. It has been shown, though, in that Prevenir open label real world study to be equally effective to daily pre-exposure prophylaxis. So again, this is about having that discussion with your patients, meeting them where they are at, and having more options is a good thing. Injectable cavitegravir is also a game changer, though. I have a lot of patients that are really interested in this, and it's a very exciting thing. And so again, this is for sexually active adults and persons who inject drugs, but it's the same indications. You want a documented HIV antigen antibody test, again, within 1 week of starting cavitegravir injections. And then you would give cavitegravir either as an oral lead-in for a month, or you can give the first dose as an injectable IM injection. Then you would follow by a second dose that is 1 month after, and then every 8 weeks after that. And so the follow-up schedule is a little bit different than PrEP. That's on our end. We just on oral PrEP. And so we just have to learn to follow a different schedule, but I'll go over the lab tests coming up shortly. And this just brings me into a discussion on multi-purpose prevention technologies that are available, all very exciting. These are all coming down the line with respect to HIV prevention technologies. So oral pills, vaginal gels, vaginal rings, enemas, vaginal inserts, intramuscular injections, microarray patches, diaphragms, implants. All of this is to say, stay tuned, but also it is just really exciting that we have so many options available for our patients and can talk to them about what works for them, what doesn't work for them, and how we can meet them where they are at. So with respect to HIV testing, they have separated it into initial HIV testing as opposed to follow-up HIV testing once someone has been on antiretrovirals. And I'll explain why, but clinicians should document a negative HIV test within a week before initiating PrEP. And ideally that should be an HIV antigen antibody test. You need to screen for acute HIV, of course, because it is important to diagnose acute HIV to prevent any kind of resistance. Remember, tenofovir and emtricitabine are the backbones of most of our antiretroviral therapy for HIV treatment. So we want to prevent things like an M184V or K65R mutations. But this is just the algorithm with respect to if an individual, before starting on HIV pre-exposure prophylaxis, what type of tests should occur. And so if it is, if the antigen antibody test is reactive, that means that they have acute HIV. If it is non-reactive or indeterminate, there is additional recommendations depending on if an individual had an HIV exposure event or if they have signs or symptoms of an HIV infection, in which point, if you have high suspicion, you would want to do an HIV RNA assay. But not so fast. Here's the thing. The reason why we separated testing before and testing after is because at the HPTN-083 study, what we noticed was that HIV detection with an antigen antibody test was delayed compared to the HIV RNA assay. In other words, the normal test that we use to screen for HIV had a delayed response when people were on antiretroviral therapy, especially cavitegravir. And so the modalities that we used previously were not as sensitive, and the delay was actually up to 98 days for incident infections, especially with cavitegravir. But it's not just cavitegravir, it was also found in TDF-FTC with that delay being up to 34 days. So it took the antigen antibody assay 34 more days, up to 98 more days with cavitegravir compared to the HIV RNA assay. Why is that important? Again, we want to detect HIV and acute HIV more rapidly. But if we have this delay, then there is worry for some resistance. Now, 30 days is not, in my opinion, is not enough for me to worry about resistance, but 90 days is quite a long time to be on one drug with an acute HIV infection. That might lead to more resistance. So I don't want this to scare people with respect to prescribing TDF-FTC. We have been using antigen antibody assays for quite some time now with TDF-FTC, and we have not seen that spike in resistance, which is reassuring. But the question is, do we need an HIV RNA assay for all patients? And so now the recommendation, especially for cavitegravir, but also for other pre-exposure prophylaxis, the oral pre-exposure prophylaxis, is to do an antigen antibody assay and a qualitative or quantitative HIV RNA assay with this algorithm showing what to do, especially if they're discordant. If they are all on the same page, you have a positive or a negative result. But if they are discordant, then you would want to send a new specimen for an HIV RNA assay. So how does this affect access to PrEP? Well, I view it as 2 steps forward, 1 step back, because again, I work in the North St. Louis County Sexual Health Clinic, and I can tell you right now, we don't have access to an HIV RNA test. The biggest bottleneck towards access to HIV pre-exposure prophylaxis is not access to the drug itself. It is actually access to testing, and insurance companies not being willing to pay for testing. I've had PrEP patients tell me that they've been slapped with bills for hundreds, even thousands of dollars just for the STI screens that is normal. That is a normal part of PrEP follow-up. And so this is a really important consideration that we need to consider for our patients, and we need to do better in order to make sure that they are not having bills coming to them for hundreds and thousands of dollars. We just need to be aware of that. And I just want everyone to know that this is something that we need to look into and we need to work harder on in the future. But we do want more people to be on PrEP, and SameDay and teleprep are exciting new ventures, and they are things that we ourselves and our SIBA are actually working on. So this is included in the guidelines as a new section, but basically what you would want is a point of care HIV test, at least an antigen antibody test, but an HIV RNA is preferred only if it provides the same day result. The recommendation is to not use the oral fluid HIV test or the buccal swabs because it is 3rd generation and it's less sensitive. And it oftentimes misses acute HIV. It has a little bit of a delay compared to the other modalities. You want to draw blood for creatinine, provide assistance for patients eligible to enroll in health insurance, medication copay assistance, and medication assistance programs. Ideally, you would have a PrEP navigator help with that. but you want to give a 90-day supply from the get-go. Previously, it was 30 days, but again, we are noticing that we want to have people do uptake and have less opportunities to not follow up with us. And so this allows patients to not have to come in with a 1-month visit and allows them to have that 90-day visit, which is much more convenient for our patients. There's also guidance on providing PrEP by telehealth, as well as home specimen collection kits. And again, these are more resources can be shared, can be seen on the primehealthco.com, which our group from the CIVA has been working actively on and did an excellent job with. But there are innovations in PrEP implementation. As you can see here, you can work with community-based organizations, PrEP clinic, mobile clinics, as well as other types of clinical settings for PrEP, such as a community healthcare center, primary care clinic, as well as specialty clinics such as an STI clinic, HIV clinic, and family planning. But the new innovations are same-day PrEP, integrated testing and PrEP in pharmacies, teleprep in clinics, community-based organizations and pharmacies, and PrEP at home with teleprep and home testing. So all of which is really exciting, especially in the era of COVID. We also have less frequent labs. At least every 3 months, you need a repeat HIV test to assess for signs and symptoms of acute HIV infection, prescription or refill for 90 days, and medication adherence and risk reduction, as well as to conduct STI testing for all sexually active individuals with signs or symptoms or asymptomatic MSM. At least every 6 months, you want to monitor creatinine clearance for individuals who are age 50 or greater or have a creatinine clearance of less than 90, or if you're noticing their creatinine clearance declining rapidly. And you want an STI screening for all sexually active MSM and transgender women. And then at least every 12 months, creatinine clearance for all patients, triglyceride, cholesterol, and weight assessment for individuals on TAF FTC, as well as chlamydia screening for heterosexual men and women. So while this breakdown seems quite complicated because you have to look at MSM, transgender women, self-identified heterosexual individuals, what I will say is that every 3 months you need to have an HIV test. In individuals with a creatinine clearance that is less than 90, then you want to check that every 6 months. And then you want to screen for bacterial STIs at least every 3 to 6 months, in my opinion, for all sexually active adults. And then a lipid panel, as well as a weight assessment for individuals on TAF FTC. As for cavitegravir, again, it's a different timeline because it's every 2 months they're coming in for this injection. So every 2 months you would want that HIV test. And then at least every 4 months you want, every 4 to 6 months you want individuals to be screened for bacterial STIs. So just a little bit of a talk about emphasizing patients taking their meds as prescribed. And I like to use the term persistence as opposed to adherence. But a brief medication adherence question, this is from the guidelines, is many people find it difficult to take a medication every day. Thinking about last week on how many days have you not taken your medication? I just always like to ask people, hey, how many missed doses have you had? And was there any particular reason why you missed those doses, and how can we help you to make sure that you take your medications? The reason why this is helpful is because we know that if you take greater than or equal to 4 pills a week, it's very effective in preventing HIV acquisition, which is wonderful. We don't tell our patients that. But I always give them a little bit of slack as well. It's hard to take a pill every day. It is hard to remember to take a pill every day. And so we need to remember that our patients are humans. And if any of you have taken pills every day, you know how hard it is. So I just want to emphasize that while we want our patients to take their medications as prescribed in order to give them the best shot at decreasing the likelihood of HIV acquisition, it is really important for us to also see where our patients are coming from as well. So this is the key components of oral medication adherence: counseling, establish trust and bidirectional communication, support adherence, and monitor medication adherence in a non-judgmental manner. But while we're talking about sexual health goal setting, I have to share this wonderful study that was done by Julia Marcus and her colleagues, basically looking at HIV pre-exposure prophylaxis and sexual satisfaction amongst men who have sex with men. And so I love this study because it actually looked at a different measure for sexual health other than especially for PrEP, other than whether or not someone acquired HIV or not. And so what they noticed was HIV pre-exposure prophylaxis, if you're taking it, you had an increased intensity of sexual arousal, increased quality of orgasms, increased sexual pleasure, an increased focus on sexual activity, better sexual reaction to partners, and better mood after sexual activity. All of which is a fantastic thing and goes in line with how we really need to look at sexual health all around for our patients and create sexual health goal setting goals with our patients. And so I love this study. It made me really happy when I saw it, and I was like, wow, finally someone looked at something other than just HIV acquisition. So what are our goals moving forward? It is really important to be aware how language affects our patients and how we discuss things with our patients. We would like more trauma-informed care and more training on this. And it comes with practice, right? The more we talk about these things, the more we catch ourselves saying things. And I have to work on this every single day, but we have to work harder on trying to make sure that the things that we say to our patients might not carry a negative connotation or a judgmental connotation. We need to educate all individuals on PrEP options and all different PrEP options, which is fantastic because, again, having more options available can only mean good things for our patients. It means that we are able to give them the medications that they want to take and allow them to take control of their sexual health in the way that they can lead and direct us. Meeting patients where they're at is really, really important with respect to sexual health, and always understanding that this is a person in front of you that has particular sexual health goals, and we need to have those discussions in a non-judgmental manner. Increasing access and identifying persistent obstacles, such as this HIV testing recommendation, which I can tell you collectively on some of our CDC meetings, we all were like, okay, but we barely have enough funds to do the testing we have now. And so this is going to be a very interesting discussion. While this, detection of HIV and early HIV is very important, it's going to be interesting to see how this plays out and how we can make sure that it doesn't decrease access to PrEP because of billing or because of lack of funding. And then last but not least, sexual health goal setting. Try to work on it with your patients. Try having these open and honest discussions with your patients. You'd be surprised what you find out. It is really remarkable, and it allows for wonderful bidirectional communications with your patients. But always remember, just non-judgmental, open discussion, and try to have a discussion of how we can meet our patients where they are at. And that's what I want you all to take away from this talk at the end of the day. And with that, I am very happy to say that I ended on time because I was worried. So
you did, you nailed it.
Woo!
Liz, fantastic. Thank you so much for sharing this. Let me go ahead and share my screen here to get everyone the QR code and give folks a chance to put any questions they have in the chat for us. We've got a question coming here from our very own Dr. Dow. Can you comment, what is the role of PCPs in prescribing PrEP? What resources are available for patients who are in low resource setting? He comments that my patient population is relatively older. How do I approach asking them about their sexual activity? Are there any best practices there?
Yeah, and so I think that's a great question. So I have sexual health discussions with every single one of my patients. I just normalize it. It just, the more that you talk about sexual health as a normal part of your primary care setting screening, the more that it just becomes a normal part of your history taking. So I don't separate based off of, oh, this is an older person, oh, this is a younger person. I just ask it with everyone, and I explain that in a way that is, it's the way that we share it is it okay if I ask some questions about your sexual health? Again, it is asking for consent. It is allowing the person to take control of that situation. Some of these topics might be a little bit triggering for people, might be associated with traumas, but it is really important to have those regular discussions. And I really highly recommend that you read that sexual health guide from the CDC, because it really does lay out some really great questions for people that should be asked on every single primary care visit. As for PrEP should be available to, I think a lot of people get really worried about how to prescribe PrEP, but I have to remind people, we give a lot of really complicated medications in primary care settings all the time. But I think the biggest issue, and I think the biggest concern for people is, how do we navigate individuals who are uninsured, underinsured? How do we make sure that they aren't footing a bill that is insane, right? And so for that, please don't hesitate to reach out to me. I'm more than happy to help navigate that. We have a great PrEP team, and you can always refer to our infectious diseases clinic because we have a bunch of resources that are available to us. But otherwise, if you have a well-insured population, please, these resources are all available on the CDC website. They are very straightforward. It gives you all of the tests that are required and when you require them. And it is, if you have any questions or concerns, please don't hesitate to reach out. But it's just HIV STI testing every 3 months and give PrEP accordingly. But the algorithm is pretty straightforward, which is wonderful. And that's how it should be.
Great, thank you for that. Dr. Barrett has, how soon after starting PrEP is one quote unquote safe?
Yes. All right. So this is a great question. Again, there's a lot of nuances to this discussion, so I wish I could have fit it all, but so what people are asking typically is, when is it fully effective, right? And so it's really hard to measure. For cavitegravir, we don't have a lot of data yet, so let's start there. But for TDF-FTC, which we have much more data on, for cisgender men, especially men who have sex with men, we know that after 1 week is where the tenofovir levels in the rectal tissue is the highest. And then for cisgender women or individuals with a vagina or cervix, it takes 21 days typically to reach a good medication level. So this on-demand PrEP, though, is something that I want, this brings up a lot of questions about on-demand PrEP. We know that on-demand PrEP, which is specifically for TDF-FTC and MSM, so cisgender men who have sex with cisgender men, it is equally effective compared to that daily PrEP. So that kind of threw a wrench into the whole system of like, okay, do we really have to take a week-long course? And so I think that taking those 2 pills 2 to 24 hours before, and then 1 pill after sexual intercourse, 24 hours after sexual intercourse, and 1 pill 48 hours after is also equally effective, and you get good enough dose levels, which is fantastic. So again, more data will come, but right now, as it stands, cavitegravir, we don't have data. TAF-FTC, we don't have a lot of data, but we know that for individuals with a cervix and a vagina, it's usually 3 weeks of daily medication to reach that higher level.
Gotcha. All right. Well, I think with that, though you ended on time, we are out of time now. My thanks again. Thank you, Dr. Cherabie, for joining us. Thank you, Dr. Dow, for bringing Dr. Cherabie. Thank you to the OutMed program. We're so glad to have you deliver these talks every year and for informing our care on some best practices. Thank you for educating us today. We really appreciate your time.
Thank you. It was wonderful.
And thank you everyone again for joining us. Please join us next week. We have our very own Dr. Willie Ross joining us. I can't wait for his talk. And following that, on the 3rd of next month, we have the director of the CDC, Dr. Rochelle Walensky. So please, you won't want to miss that. So come back and join us again soon. Thank you all very much. Have a great day.